Hi everyone, welcome to today's lecture. Today we will be discussing pancreatic diseases, specifically acute and chronic pancreatitis. Here are the learning outcomes. I'll give you a second to read those. Basically, we're going to review normal function, define acute and chronic pancreatitis, characterize the pathophysiology of acute and chronic pancreatitis, and also describe the medical nutrition strategies for these conditions. Next, let's review the digestive system and how the pancreas functions within it. The GI tract is also known as the alimentary canal. It is a series of hollow organs. Food passes through it, through the GI tract for digestion. The accessory organs of the digestive system include teeth, tongue, salivary glands, gallbladder, liver, pancreas. These all aid in digestion, but the food does not pass through them. The pancreas is a retroperitoneal organ. It is located behind the stomach between the duodenum and the spleen. It has a shape similar to a tadpole with a head, a body, and a tail. The pancreas is the only gland that performs both exocrine and endocrine function. 80% of the gross weight of the pancreas is dedicated to supporting exocrine function, and the remaining 20% is dedicated to endocrine function. The digestive enzymes are produced within the acinar cells of the pancreas. These digestive enzymes include trypsin, chymotrypsin, amylase, and lipase. The trypsin and chymotrypsin are proteases, and they are actually produced in a precursor form, referred to as trypsinogen and chymotrypsinogen. They are rather dangerous enzymes to have in the cells, and packaging them as their inactive precursors is a way for the cells to safely handle these enzymes. The secretory vesicle also contain a trypsin inhibitor, which serves as an additional safeguard should some of the trypsinogen be activated to trypsin. However, once the zymogen vesicle with the trypsinogen and the chymotrypsinogen has been exocytosed into the duodenum of the small intestine, the inhibitor is diluted out and becomes inactive. The pancreatic juice is composed of two secretory products critical to proper digestion: the digestive enzymes and bicarbonate. The epithelial cells in the pancreatic ducts are the source of this bicarbonate and water secreted by the pancreas. The bicarbonate is base and is critical to neutralizing the acid coming into the small intestine from the stomach. The pancreatic lipase is responsible for breaking down the triglycerides into their component parts, the monoglycerides and the free fatty acids. The amylase functions to break down the starches in the food. The endocrine tissue consists of islets, specifically the islets of Langerhans, which house the beta cells and the alpha cells, which are their hormones and metabolic hormones, and they're involved in blood glucose regulation through the production of insulin and glucagon. We also see the delta cells promoting somatostatin, which has some inhibitory effects on the GI tract. On this next slide, we'll do a quick overview of digestive function of the pancreas. So what happens is, as the foodstuffs leave the stomach, it has been converted into an acidic chyme, and it contains partially digested proteins and fats, which stimulate the release of cholecystokinin from the mucosal epithelial cells. Cholecystokinin is the principal stimulus for delivery of pancreatic enzymes and bile into the small intestine. The acidity of the chyme stimulates the release of secretin, also from the mucosal epithelial cells. The secretin then stimulates the release of bicarbonate and water from the pancreatic duct cells. As they are secreted into the pancreatic juice with the digestive enzymes. The importance of this is that the bicarbonate will help neutralize the acidic environment of the duodenum so that the digestive enzymes are not destroyed by the high acidity. Once the digestive enzymes have been transported into the duodenum, the enterokinase enzymes within the brush border membrane activate the chymotrypsinogen and the trypsinogen. Actually, the trypsinogen first. And it's this trypsinogen which is now converted into its active form, trypsin, and that trypsin then sets off a whole cascade of events, activating all of the other precursors to active enzymes. It can also activate itself. Now, in their active forms, the trypsin and chymotrypsin digest the proteins into peptides and peptides into smaller peptides. The lipase breaks down the triglycerides into the free fatty acid, and we also see the amylase breaking down the starches. Now that these foodstuffs are being broken down into their smaller components, we see, interestingly, the cholecystokinin is no longer stimulated. And that was a quick overview of the digestive mechanics of the pancreas. Next, we'll look at the disease state, pancreatitis. Pancreatitis is a rare disease in which the pancreas becomes inflamed. Primarily, we see pancreatic damage occurring to the digestive enzymes, specifically when the digestive enzymes are activated, and we see autodigestion. We see these enzymes destroying functional pancreatic tissue. This is what happens in severe cases, and we also may see bleeding, hemorrhage into the gland, and we also may see infection, and fluid collection may also occur. Also in severe cases, we may see damage to other vital organs, such as the heart, the lung, and the kidneys. Acute pancreatitis is one of the most common reasons for hospitalization with a gastrointestinal condition. The two most common causes for acute pancreatitis are gallstones, and then followed by excessive alcohol abuse. Chronic pancreatitis is where we see long-term inflammation, often characterized by the death of or necrosis of functional tissue and its replacement with fibrotic tissue. That next question, when does acute pancreatitis transition to chronic pancreatitis, has been a rather challenging question. The two, given that we really don't know what the originating pathology is, it's been suspected that it's either due to the injury to the acinar cells, or it is from obstruction, or and the other question is one a result of the other? Part of the challenge is that with acute pancreatitis, it's a self-limiting disease and it's a fast course, and to really investigate the true pathology of the disease, we would need a sample of the pancreas during that time of inflammation, and that's just not possible. During some of the challenges with chronic pancreatitis is that occurring with diagnosis, there is no well-defined clinical spectrum or course of the disease, and often patients aren't diagnosed until their late stage. There have been a number of theories and postulates trying to determine what this relationship is between acute pancreatitis and chronic pancreatitis. Are they even related? Does acute really transition to chronic? And so I'm not going to get into all of those different postulates, but I'm going to fast forward to 2000 when there was a genetic discovery. That genetic research led to the development of the SAPE hypothesis. SAPE is an acronym for single acute pancreatitis event, and what they investigated, they were looking at idiopathic idiopathic pancreatitis in children, and also hereditary pancreatitis. And what they found was that there was this importance in trypsin, specifically in the trypsin inhibitor, also known as SPK1, and they found this. There was a mutation in that gene. Well, I won't go over all the details which display this link between the important initial trigger or injury. If I provided a diagram that shows you, there's a pathway on the left, and then on the right it shows the changes to the functional tissue of the pancreas. And what the diagram displays after this initial injury is, as we get down to the bottom parts, is that it's this deranged inflammatory response. We see that there's a imbalance between the anti-inflammatory, which is supposed to be the healing part of inflammation, and the pro-inflammatory, which is the function that produces derangements in the tissue. And we see this response system that is not responding appropriately, and then it becomes a hypermetabolic, hyper-inflammatory state. And actually, we're going to see that later as well. The next slide also shows an inflammatory response, and I thought this could hopefully explain things more, in that how this hyper-inflammatory response can just wreak havoc throughout the body. And so this next diagram shows a hyper-inflammatory response followed by an immunosuppressive phase, during which multiple organ dysfunction is present, and then leading to susceptibility to infections. This combination of pro and anti-inflammatory markers could help possibly identify patients who are developing sepsis, or before we see the onset of organ dysfunction. Okay, I gotta get going. I'm only on slide 9. So next up, acute pancreatitis. Acute inflammatory condition characterized by the onset of persistent abdominal pain associated with injury to parenchyma, the acinar cells, really, resulting from premature activation of digestive enzymes and leading to further derangement of pancreas, surrounding tissues, and nearby organs. And I kind of term this the intra-abdominal catastrophe. Diagnostic criteria for acute pancreatitis has been developed by the Atlanta classification system, which they actually, their last revision was in 2012, and that was subsequent to their initial classification, which was in 1992. Wow, and it's now 2020. Well, so they developed this classification system, and I will show you what it is in a second. And the American College of Gastroenterology have developed a guideline for the management of acute pancreatitis, incorporating the classification system. This next slide shows the latest classification system done in Atlanta 2012, and this is how they characterize the acute pancreatitis. It is has 2 phases. Early is the first week. Late is the after the first week. Severity is mild, which is related to no organ failure, moderate organ failure less than 48 hours, or severe organ failure longer than 48 hours. They've also assigned it 2 types. One is edematous, and the other is necrotizing. Some of the complications they've also assigned here were in less than 4 weeks, acute peripancreatic collection, greater than 4 weeks, pseudocyst, and then we also see greater than 4 weeks acute necrotic collection, and greater than 4 weeks walled-off necrosis. So then those are complications. Each 2 of those are pertain to the edematous or the necrotizing. The changes to the classification system, the goal was to provide better understanding of the pathophysiology of organ failure and necrotizing pancreatitis, including their outcomes, and it was also using improved diagnostic imaging to provide a standard, to provide a guideline how to classify this disease. I should also note that this classification was developed by a global consortium of participation by pancreatologists. From this, the definition of diagnosis for acute pancreatitis was developed. Of the following three features, which I show on the next slide. So the first one is abdominal pain, consistent with acute pancreatitis. What it is, it's a rapid onset of persistent severe epigastric pain, often radiating to the back. The second one is serum lipase or amylase activity, which is at least 3 times greater than the upper limit of normal. And 3, CT scans or magnetic MRI scans, which provide characteristic findings of acute pancreatitis. We should also note, though, with these lab values for or criteria for amylase and lipase, that there's limitations in sensitivity and specificity and positive and negative predictive values for serum amylase. Serum lipase is preferred. Some of the other challenges are that amylase rises within a few hours after the onset of symptoms. It returns to normal values within 3 to 5 days, and it also may remain within normal range on admission in as many as 1/5 of the patient. We also see serum amylase concentrations may be normal in alcohol-induced acute pancreatitis and in hypertriglyceridemia. With regard to the contrast-enhanced CT scans, while they're useful to confirm the diagnosis, but the routine imaging is just generally unwarranted in mild and uncomplicated courses. The next slide shows some of the signs and symptoms, and again, we just mentioned it in the criteria, that we see epigastric pain, sharp, severe, radiating, nausea, vomiting, diarrhea. We see fever, weakness, tenderness, distension, tachycardia. And if you look at the images on the right, picture A is a bruising umbilicus called Cullen's, and B is referred to as Grays-Turner, and you see bruising on the flanks. And both of these indicate retroperitoneal hemorrhage. And we also see typically elevated amylase and lipase in this population. But again, they're not always the best prognostic factors for the reasons I mentioned earlier. Next, we will talk about the etiologies. First, we'll talk about the metabolic etiologies. This includes alcohol abuse, smoking, hypertriglyceridemia. Alcohol itself is a direct and indirect trigger for acute pancreatitis. Smoking is also a direct trigger. And what we've also seen is that the combination of smoking and alcohol has an amplified effect on the risk for acute pancreatitis. Next, we have biliary diseases, which is gallstones, and I wrote it twice because it's gallstones, microlithiasis, biliary sludge, and choledocholithiasis, and choledocholithiasis is gallstones. And that's more obstructive. We also see there's mechanical or obstruction in iatrogenic, which is a post-ERCP, and ERCP is endoscopic retrograde cholangiopancreatography, and it is also an etiology for pancreatitis. It's a procedure that enables a visualization of the pancreatic, the pancreas and bile ducts. The problem is that it's been shown to cause injury in some patients, to direct injury to the pancreas, and they end up with post-ERCP or PEP. I can say that. Endoscopic retrograde cholangiopancreatography pancreatitis. That's a mouthful. The next one is pancreas divisum, and that's it's a congenital abnormality, and the result is the pancreatic juices are exiting the pancreas via an alternate duct, not the common bile duct. And what we've seen in those patients is that it's characterized by abdominal pain. The next is genetic, and the first gene mutation we see is the PRSS1 and SPINK1, and the SPINK1 is the trypsin inhibitor, which is also related to the SAPE hypothesis. We also see genetic mutations leading to acute pancreatitis and celiac and cystic fibrosis. Other etiologies include there's idiopathic, vascular disease, infections, parasites, and scorpions. And although we have all these, there's quite a few etiologies, the pathology follows the same course, and we're going to see that it all leads to that's the potential for that hyper systemic inflammatory response, which is just deranged. And actually it's called systemic inflammatory response syndrome, SIRS, which if developed then can actually lead to multi-organ dysfunction syndrome, also known as MODS. Okay, so I'm going to describe the pathophysiology for the first two, most common, gallstones and alcohol. And I've included a little video here, and it should be playing, and it shows exactly what happens as the gallstone creates that blockage. But so the gallstone, the migration to the common bile duct blocks the sphincter of Oddi, and what we see then is a backup of pancreatic secretions, which increase this pressure within the pancreas. And then the pressure compresses the pancreatic blood vessels, causing tissue ischemia. And then we see the activation of inactive proteases, the zymogens. And what happens is they start to digest the pancreatic tissue. So we see that premature activation of digestive enzymes within the pancreas. And what that leads to is then we'll see necrosis or the death of pancreatic cells. So as this continues, then we start to see this massive systemic inflammatory response, it can go a number of ways. So that response can lead to further complications. So local complications, which are identified as pancreatic pseudocysts, which are enlargement of the pancreas due to fluid accumulation, or pancreatic necrosis and abscesses, the death of the pancreas. But some other routes related to the systemic inflammatory response, or SIRS syndrome, is that it self-perpetuating. This response keeps generating more and more necrosis. It triggers this inflammatory response, triggers more cytokine release. It triggers inflamed pancreas, irritates adjacent intestines, causes ileus. It causes more inflammation, the increased permeability of the blood vessels, and then we see leaking fluid into the pancreas. And from there, we see that these, for instance, the cytokine release leads to fever, nausea, vomiting. We see, or in the permeability of blood vessels, we see, and here's a big problem, we see profound dehydration. And as you'll see later when we get to severe pancreatitis, in the management of it is, aggressive rehydration, because one of the common things there is persistent hypovolemia. Next, we'll go through the pathophysiology for alcohol. Okay, I should also preface that exact mechanisms aren't really known. These are hypotheses. These are theories. And the current one with alcohol, it's now generally accepted that alcoholism related in acute pancreatitis and chronic pancreatitis are the same disease at different stages. I should have put all my diagrams together for this, given that the pathophysiology is the same for acute and chronic related to alcoholism. All right, so there's a figure here, and I have a figure that I'm going to show later. But it shows the overall hypothesis for the pathogenesis of alcoholic pancreatitis. And it's postulating that ethanol and its metabolites and the oxidant stress exert a number of toxic effects directly on the pancreatic acinar cells. And we've talked about those throughout, that those are the cells responsible for producing the digestive enzymes. And this toxic effect then activates these inactive enzymes, which leads to autodigestion. So what we see is a destabilization of lysosomes and the zymogen granules. Those zymogen granules are what house the inactive forms. It's mediated by the oxidant stress. It accumulates in the pancreas during ethanol consumption. This can get really complicated really fast. What we're finding is that these acinar cells are metabolizing ethanol, and we're seeing that it's leading to increased fragility of these zymogen vesicles, which then leads to the activation of its contents. But we're also seeing that there's this oxidant, so we have that autodigestion from the ethanol acting on the zymogens, but then we also see that it's producing reactive oxygen species, which are acting upon the stellates, the pancreatic stellate cells, and it's leading, so that oxidative stress is activating this stellate cell, which is then, it becomes fibrotic. It produces fibrotic tissue within the pancreas where it shouldn't be. And when the ethanol is activating or leading to the fragility of these zymogen granules, and we see the autodigestion, what we're seeing is this necrosis. Well, guess what? The necrosis is related to the recruitment of cytokines, and then the cytokines also amplify the stellate cell activation, implicating now that everything together, what we're seeing is an amplified activation of this pancreatic stellate cell, or PSC. So we have an amplified fibrotic response. This next slide is it's more of the same. What it is showing is the routes, how the etiologies, regardless of what they are, they're on a very similar, the pathology is very similar in that we're going to see some sort of, there's a seminal event, and we'll see injury to the acinar cell, activation of these inflammatory mediators, pro and anti, and then we'll also see, this obstruction as well, but then we'll see that localized response, the fluid accumulation, and then because there's leaking, we'll also see injury to other organs, other tissues that are not local. What we see because of this, we'll see the increased serum amylase, we'll see the increased serum lipase, and that also leads, this lipase is active. What it leads to is to fat necrosis, and the proteases, which are now leaking beyond autodigesting the pancreas, then we see vascular destruction. And all of those have implications with recruitment of pro-inflammatory and anti-inflammatory cytokines, which lead to, again, to that just self-perpetuating systemic inflammatory response syndrome. So I'm not really going to go into the next slide. The next slide, though, is that bigger picture of this cytokine storm that looks at this, the whole cascade of events with these chemokines and these interleukins, and also describing the pathogenic mechanisms involved. It's a great diagram, and it'll show you how this amplification of the abnormal inflammatory response leads to the systemic inflammatory response syndrome, localized tissue and distant organ damage, multiple organ distress syndrome, and even some of the bacterial translocation. Now we're going to transition to talking about nutritional considerations and nutritional management strategies for acute and chronic pancreatitis. So this first one is in the context of malnutrition. This population, given now that you've seen what a complex disease process it is, and the high risk for being in a hypercatabolic state, for increased needs for tissue repair, tissue regeneration, they should automatically be considered as moderate to high nutritional risk. NPO status has typically been standard protocol for this population. The idea is give the pancreas rest. Do not stimulate exocrine secretion, exocrine function until the pain subsides. But what we're seeing now in the literature is that this population, they could still receive enteral nutrition, and we found that it doesn't really depend where, but that they are receiving enteral nutrition more. And the rationale behind that is that it's supporting the integrity of the gut barrier, and which does play a role in critical illness. And what we've also seen is that whether the feed originated in the duodenum or in the stomach, that it was minimal. It was minimal exocrine secretion with either delivery. Another consideration is the patients who have the alcohol-related etiology. We already know that in the absence of pancreatitis, that the person who's abusing alcohol already has a higher risk for malnutrition. We already know that in the alcoholic population there's inadequate intakes and which result in deficiencies in folate, thiamine, vitamin B6, and vitamin A. That said, a special consideration should be given to thiamine and folate supplementation for this population to prevent the onset of encephalopathy and or anemia. Given these compounding factors, it is warranted that 24 to 48 hours post-admit that the patient should receive a comprehensive nutritional assessment that includes a nutrition-focused physical exam to determine their malnutrition risk, and if they have any muscle wasting, subcutaneous fat loss, vitamin and micronutrient deficiencies. Also looking at determine their functional status, as well as assessment of their dietary intake pattern. So this next slide, I constantly ask myself, well, what does the literature say? So what about initiating nutrition support and in patients with mild or moderate acute pancreatitis? Well, what they found is the initiation and type of the oral diet is debatable. What they found was that whatever they fed them, we saw a decreased length of stay, and it didn't necessarily, there was not associated pain with it either. We found that it's been discovered that low fat was well tolerated, that solid diet versus clear liquid diet resulted in shorter length of stay, and also the absence of abdominal pain. Additionally, that in this population that enteral nutrition was preferred over parenteral for the same reasons. Next, we'll look at determining calorie and protein needs. Indirect calorimetry is the gold standard for determining resting energy expenditure in the critically ill population, and we need to determine that to see what their needs are at this time. Again, think about how they've been in this hypermetabolic state. However, if that is not available, you're able to use a weight-based nomogram. Next, we'll look at assessing nitrogen balance. And why is that important? I think Dr. Roberts said it's not done much anymore, but that the rationale was that a negative nitrogen balance is often seen in severe acute pancreatitis and may also correlate with an adverse clinical outcome if the protein losses are large. And these can be as high as 20 to 40 grams per day in severe cases. So the goal here is to minimize protein loss, and that we are compensating for this increased protein turnover. You can also think about it that in severe acute pancreatitis, where we also have this risk for sepsis, that we're also going to see that an increase in the resting energy expenditure. That is why we need to strategize and minimize the catabolic stress. Patients in the ICU should be also weekly reassessed for their energy needs. This next slide shows a nutritional management algorithm, and it largely follows what we've been talking about, so I'll let you have that. It's a great diagram. Okay, these next two slides are going to describe the nutritional management for mild and moderate acute pancreatitis, followed by severe. And this is all what is indicated in the literature. And I've also included beyond these actually, well, let me go through these first. Okay, so for mild to moderate acute pancreatitis, advance to oral diet within 7 days, low fat diet after short duration. Again, shorter the MPO as possible. Patient to be reassessed, and it's recommended to move them to enteral if they're not able to advance to oral within 7 days, or if their disease severity has gone from moderate to severe or to severe pancreatitis. Some other considerations: education with intake considerations, calculating energy needs, monitoring for dietary fat tolerance, early satiety. Fiber supplementation is controversial, not recommended for patients in the ICU due to delayed gastric emptying. Perhaps soluble fiber for mild if they're experiencing diarrhea. Okay, now we're going to talk about severe nutritional management for severe acute pancreatitis. Again, so you'll see at the top of the list a fluid resuscitation, and I had mentioned earlier about the hypovolemia. So this rationale for early aggressive hydration is from frequent hypovolemia that occurs from multiple factors affecting patients with acute pancreatitis: vomiting, reduced oral intake, third spacing, increased respiratory losses, diaphoresis. It's also hypothesized about the effects of the edema of the inflamed pancreas, leading to decreased blood flow, increased cellular death, necrosis, in this whole cascade of this inflammatory response. So it's increasing vascular permeability, third space fluid losses, and worsening hypoperfusion. That was a lot. It's for all of those reasons that the number one thing here is the early aggressive fluid resuscitation to help to combat the complications and such as the pancreatic necrosis. Early initiation of enteral nutrition, 24 to 72 hours post-admit, also depending on what their nutrition risk score was, and due to, again, we've said this many times, their increased metabolic demand. In regards to immunonutrition, what we see is increased demand for vitamins that are related to cell-mediated immunity: A, C, E, B6, folate, B12, pantothenic acid, iron, and zinc. Arginine has been seen as safe in doses of 15 to 30 grams. However, it is not currently recommended by Aspen, and I think it is due to some of the concern related to hemodynamic instability, related to vasodilation. Glutamine has also been investigated for its antioxidant properties and potentially enhancing intestinal health, preventing bacterial translocation, but the results have been mixed, and Aspen doesn't endorse glutamine supplementation in acute pancreatitis either. As for omega-3, again, it does show promise, but it's still not recommended. As far as enteral nutrition formulas suggested for use in acute pancreatitis, polymeric formulas should be first trialed, and if there's no indication of malabsorption and intact GI anatomy. It's important here actually to start talking about the tolerance for enteral nutrition formulas. This is a good point to also discuss the considerations for tolerance strategies for EN. Typically, we want to give a slower infusion over a longer of a period of time. We've seen that is better tolerated by patients with compromised absorption. We need to also consider monitoring carefully patients suffering from obesity, because they are not going to be able to meet their nutritional goals as rapidly. We also need to consider nausea related to poor gastric and intestinal motility. Diarrhea is also common in acute pancreatitis. So we want to be conscious of these indications as they relate to enteral nutrition delivery. The next slide just provides a list of medication management used to improve enteral tolerance. The next two slides were more for reference for you, and I'm posting the paper as well. But they're the most current. These are the European Society of Parenteral Enteronutritional Guidelines for acute and chronic pancreatitis, which was just published in March of 2020. And if you compare this to the ones that we presented earlier, they're identical, similar. We've made it to chronic pancreatitis. Chronic pancreatitis is an irreversible, progressive, fibro-inflammatory disease characterized by maldigestion and malabsorption, abdominal pain, and often leading to exocrine and endocrine insufficiency and malnutrition risk. This next slide just shows you it compares a normal pancreas to a diseased pancreas, and if you look at the one on the right, you can see all of the white areas are fibrosis. This is where we see this destruction of tissue. The prevalence of chronic pancreatitis is 40 to 50 per 100,000 persons. It affects men more than women at a ratio of 4 to 1. We see it affecting more black people than white people, and typically develops between the ages of 30 and 40. With respect to quality of life, it's worse than any other chronic disease. It also has an independent effect on the physical quality of life. It's quite debilitating. You cannot do anything. The constant pain is a predominant factor. Some other statistics on this disease: we see a 13-fold increased lifetime risk for pancreatic cancer, 69-fold increased risk for pancreatic cancer when it's related to its hereditary pancreatitis. Okay, I think you understand that chronic pancreatitis just opens the door to cancer risk. Chronic pancreatitis seems to involve genetic factors and environmental factors. Studies have identified gene susceptibility associated with the loss of function and mutations. There are two main theories on the pathogenesis of this disease. One theory is that it's due to impaired bicarbonate secretion, which isn't able to meet the demands of increased secretion of pancreatic enzymes. And what happens then, we see the abundance of these proteins combine to form plugs within the lobules and the ducts. So then we end up with this stone and duct theory. And I'm thinking that this should make sense to you at this point after going through the different pathophysiologies for acute pancreatitis. This leads to the calcification and stone formation. I should have finished that first before I talked. Okay, the other theory, so there's the stone and duct theory. The other theory has to do with, again, it's necrosis. The other theory deals with the activation of the digestive enzymes within the pancreatic gland, and due to genetics or also alcohol. And what one study is proposing is that alcohol affects the cell's ability to respond to calcium signaling, and that this alters a feedback mechanism which promotes a cycle leading to cell death. And perhaps it's easy to have to wrap your hand around it if we think about it how we've been discussing it, is that we see that activation of the pancreatic enzymes within the pancreas, and how that leads to that autodigestion, and how that influences the development of the cascade of pro-inflammatory and anti-inflammatory events, leading to that systemic inflammatory response. And think about it over long term, it would be disastrous. I'm sorry. The next slide looks like a laundry list, and I'll go through some of these, and we've talked so much about these symptoms and signs of pancreatitis. So for chronic pancreatitis, it's chronic inflammation. We show it's over a longer period of time. one of the differences between, actually there's a few differences between acute and chronic, is in chronic we see that there's that fibrotic tissue. We see that there's the evidence of pancreatic stellate cell activation, which leads to fibrosis. We've seen also, one of the others is that the risk for malabsorption and maldigestion in advanced stages is apparent, and this doesn't happen in acute pancreatitis. As you review this list, it's not hard to decipher how many of these symptoms have direct nutritional implications or worsening nutritional status. The next slide shows the classification system for chronic pancreatitis. What we see, it has a mnemonic. It's Tagaro, and what these are etiologies that are grouped by risk modifiers. They may interact to produce pancreatic disease. It's based on this two-hit hypothesis that an individual's risk is decided by one or more risk factors. And this, again, we're going to see a cascade of steps triggering that ongoing stress, which are not apparent. All right, so Tagaro is toxic, metabolic, idiopathic, genetic, autoimmune, recurrent, and severe acute pancreatitis, and obstructive. The next slide shows a study comparing smokers to non-smokers and the incidence of diabetes, and also the incidence of calcification after being diagnosed with pancreatitis. If we look at the ones on the bottom, so the bottom two, on the y-axis we see the cumulative incidence of diabetes, and the smoker has a higher, it's not as dramatic, but when we look over on the right-hand side, that after time of diagnosis, that if the person doesn't smoke, they have a much lower risk for developing type 3 diabetes than the smokers do. And if we look at the top two, where we see the cumulative incidence of calcification, we see that it's much less in the non-smoker than the smoker. And then if we look at the calcification incidence compared to time of after diagnosis, it's even more dramatic. And what this just it shows you that, there's this significant increase in developing diabetes after the diagnosis of pancreatitis, but also that there's this higher incidence of calcification leading, and then again, the calcification, these stones are appearing within the pancreas, so then we're also seeing these increased risk for obstruction. The next slide just shows you the multiple hits target. It shows you like it's an example of smoking and alcohol, and how they directly affect the endoreticulum stress within the acinar cell, and how they are also activating the pancreatic stellate cells, which, as you know now, are once activated, lead to the development of fibrosis within the acinar cells. Again, the next slide just shows the connection between alcohol intake and smoking on these acinar cells. I think I've showed you these to death, but they're good slides. And the next one shows also the activation of the pancreatic stellate cells. I really went to town on showing you these mechanisms. Okay, medical treatment. So there isn't a current universally accepted diagnostic tool or gold standard for chronic pancreatitis. So I'll describe some of the tools that they do use. There's histology. Histological features of chronic pancreatitis include this parenchymal fibrosis, the acinar atrophy, ductal distortion, and intraductal calcification. But it's also limited to, again, because there's no universally accepted standard, so there's a lack of consensus on this one. However, it may be the most specific method of diagnosis. Then we have radiological images. Computed CT scans are a widely used modality, and they're reliable. It's a classical diagnostic chronic pancreatitis tool. There's also MRI. And we also have endoscopic studies, or EUS, ultrasound. We also have pancreatic function tests, and what these do, there's a direct pancreatic function test. We do have a couple of a test called pancreatic function test. One's kind of invasive. It's called a direct pancreatic function test, and it tests the excrement function directly and indirectly. It involves stimulation of the pancreatic cells using secretin, cholecystokinin, CCK. That is cholecystokinin. But they're invasive, and they're expensive, and not widely done outside of specialty centers. Indirect pancreatic function tests don't have the same challenges as the direct pancreatic function test. So the indirect pancreatic function tests include fecal elastase, fecal fat measurements, and serum trypsinogen. So the 3-day fecal fat collection requires a collection of stool for a 72-hour period following the ingestion of a precisely measured quantity of fat. Usually it's about 100 grams per day. And then what's measured, we look at for the excretion, if it's more than 7 grams per fat in the stool per day, and what that indicates is, or infers, is fat malabsorption, while if it's greater than 15 grams per day, it's considered severe fat malabsorption. But as you can imagine, a 3-day fecal fat assessment may be a bit much to ask patients to do, and also the lab personnel. So it's not routinely done. But in general, this indirect test is moderately sensitive and specific for diagnosing advanced chronic pancreatitis. Another indirect test is the pancreatic elastase 1, fecal elastase 1 test, also FE1, and it's a human-specific enzyme that is not degraded during intestinal transit, and we see a 5-6-fold amount in the feces, and it's a test of pancreatic excrement function. The benefits to that is that the patients don't have to consume a certain amount of food prior to testing, and they also don't have to stop any pancreatic enzyme replacement therapy. But on the flip side, it's not a good indicator of the severity of disease. As far as imaging goes, the CT scan has the highest sensitivity for calcifications. It's the highest sensitivity for diagnosing chronic pancreatitis complications. Some of the disadvantages, they're not always the clearest. It's not the best visualization of the pancreatic duct. And also it's not sensitive enough to detect early chronic pancreatitis. Treatment for CP begins with medical management. Alright, so some of the things to look for is pain control, addressing pancreatic exocrine insufficiency, making sure they are receiving appropriate nutrition referral, looking at behaviors surrounding smoking and drinking, also whether or not they require insulin. Some of the assessments to be made would be like DEXA to measure bone mineral density, as osteopenia has high prevalence in this population, and also because we already know about the contributions from excessive alcohol consumption in the absence of the disease, we'd also serum albumin, prealbumin, serum 25-OH, vitamin D should also be monitored. Okay, we're at the last slide. I know. Thank you if you're still there. We went through a lot. Okay, so nutritional management. I'm going to go through this quickly. I bet you're already tired. As in acute pancreatitis, there should be malnutrition screening within the first 24 to 48 hours. Again, because there's a high risk for nutritional deficiencies and nutritional risk in this population. This should also include a comprehensive nutritional assessment, a nutrition-focused physical exam, functional assessment, and a diet history plan. The diet recommendations should include resting energy estimation to make sure that there is adequate kcal intakes because of increased energy needs. Frequent small meals, 4 to 8 per day. Carbohydrates should be according to if there's type 3 diabetes. Protein in the range of 1 to 1.5 grams per kilogram. 30 to 40% of kcal should come from fats, and that vegetable fats are tolerated. I said it again, I guess it's important. Increased frequency of small meals. Supplement fat and soluble vitamins as indicated. Low fiber. And if weight gain is indicated, medium chain triglyceride oil, maximum of 50 grams per day, and oral supplements. Okay. Sorry if that was rushed there at the end. So the last three, again, so I've also included the most current guidelines for chronic pancreatitis from the European Society for Parenteral and Enteral Nutrition, which were published in March of 2020. And so those are these next 3 slides. I want to thank you for your time and your attention today. And if you have any questions, email me. Okay, thank you.